This is one of our earlier cases, but I think when injecting minimal blanching, in darker skins, blanching is very difficult to visualize. A quick tip is avoid multiple puncture sites. In the Indian skin, you can get a post-inflammatory hyperpigmentation at every point of puncture. So try and avoid multiple puncture sites, otherwise treat for PIH as usual. Recently, we've been using the injection pen, so I'm going to show you that. I've had it in the office for about a year. We're pretty happy with it. Hyaluronidase. Now, hyaluronidase injection is prepared. It's basically an enzyme. You dilute 0.5 cc of 150 units with 1.5 cc of 1% lidocaine with epinephrine. The injections can be given intradermally or into the bulk of the nodule. And the results take 24 to 48 hours. It's used in the treatment of complications. Urticaria and angioedema have been reported in less than 0.1%, but I can tell you it's a definite risk of angioedema. So do it with all your management of an angioedema case. Full protocols are available for vascular occlusion. We have a protocol under publication. 2% nitroglycerin paste, hyaluronidase injections. Here you need to liaise with your surgeons. If somebody's going in for a vascular necrosis, they may require the debridement and treat it as an emergency because you're going to have a very unhappy patient otherwise. Granuloma formation, ischemic necrosis. We have reported complications. It's in publications, semi-permanent fillers. A lot of the semi-permanent fillers available 8 to 10 years ago when we started fillers, they're now been withdrawn from the market. We have two cases. We've got the 61-year-old female. She had had a filler in the Gulf in 2004. She had articol injected. There was no history of any other filler injection. She did say she had a tendency to keloid. There were no visible keloids. She had had a hysterectomy and the scar was normal. And the swellings which she presented with. Let's see a picture. Can you change the slide, please? It's not moving. Okay, next slide. Right, so this patient came in to us and she had these swellings on her nasolabial, her glabella region, and she had had 3 injections of intralesional steroid. Next slide. Again, both the sides. And she was quite distressed. She was a doctor's wife. She had done the injection without telling her husband, and these swellings were just not going away. So here's a classical case of when the plastic surgeons and dermatologists worked together. And my plastic surgeon took her into the theatre. Yes. Okay. And we took everything out. So, when you're starting out with a filler and you end up removing everything, this can be a potential nightmare to deal with. Patient walks into an office, has had a procedure done, and she ends up in the hospital. She's having all this surgery done. And they took it out from each side. So, can we move it? Okay, this is what we took out. All the 3 biopsies showed multiple foreign body granulomas. And we did special stains. And articol is basically microspheres of polymethyl methacrylate. And it's pretty much off the market now, but all the complications are coming up. Second patient had had dermal. She had had multiple injections. I gave her 6 injections of intralesional steroid to try and bring it down. We didn't get anywhere with this patient. And this patient was camouflaging. She was using makeup all the time, and that was how she was living with it. So again, we did surgery. We took it out. And the excision biopsy, again, foreign body granuloma. So, I think when one talks about permanent fillers, I think you need to be very, very cautious, semi-permanent and permanent. They produce long-term results, and they have been associated with a reportedly low incidence of adverse effects. What's happening is people are not reporting their complications. It's not that they don't exist, they're not coming into